Under the evaluation and management of nose disorders, it's very important for us to discuss rhinitis. We are particularly looking at allergic rhinitis as a condition characterized by sneezing, rhinorrhea, and nasal or pharyngeal itching related to an allergen exposure. In severe cases, symptoms of fatigue, headache, and cognitive impairment are known to present. So this is quite a life-altering or quality of life-altering condition. Epidemiologically, we know it's caused by immunoglobulin E-mediated hypersensitivity response to foreign allergen. It can affect any age. Temporal correlations with exposure to allergens include pollens, weeds, trees, grasses, dander, dust mites, insect stings, cockroach droppings, mold spores, and medication. Prevalence varies by location and airborne allergen quality, and we do believe that at least 14% of Americans are affected by rhinitis, but probably much higher than that. The pathogenesis is when an allergen is inhaled, the IgE attaches to that mast cell within the mucosa and stimulates a release of histamine and leukotriene, causing local tissue edema and increased damage. This is an important pathogenesis because this leads you to understanding what the treatment is with antihistamines and leukotriene inhibitors. So clinically, our patients present with seasonal or recurrent sneezing, disturbed taste or smell, nasal congestion, a dry mouth, postnasal discharge, clear, thin, watery, and fatigue. They usually have puffy, itchy eyes. When the symptoms occur in home in the winter, that directs you to possible allergens because of our heat and that circulation of dust. That's an important fact to note. And then when seasonal is the provoking, allergens are provoking, you're really going to see that in the timing of the year. Spring and summer really implies environmental causes. Physical exam, you want to examine with a nasal speculum or otoscope, and just make sure you've got that number 4, the largest of the speculums for the otoscope. Mucosa is usually pale. Swollen nasal tubernates with bleeding, crust, and signs of inflammation. And they can have enlarged tonsils, some postnasal drainage. Often you'll see the allergic salute in a child or adolescent, and that's really where they take the back of their arm and they rub their nose, get the drainage off, and it actually causes a crease across the nose. So it's become known as the allergic salute, but you'll just see a little crease on the skin of the nose. And conjunctival irritation. Diagnostically, it's primarily clinically based, okay? There is a process called the Wright stain, but I haven't been exposed to that in primary care. We can definitely send them to the allergist for testing so we can identify which allergens are provoking, and then RAS test is something that's interesting to read about and understand that process in diagnosing. Management and treatment from a primary care standpoint is it's important to control anything in the environment you can, okay? So that's talking about minimizing direct and indirect exposure outside, okay, clothing and a mask, and caution to not bring the allergens in the house on clothes, shoes. You need to keep the windows closed, bathe and change clothes so you don't bring those allergens from outside in. Pets should be out of the bedroom at all times. That's where you're at the majority of time in your home is in that bed. Bathing pets and bed weekly and their bedding weekly is really important, and proper ventilation and changing out filters. Using mattress and pillow allergen covers, and I mean those the true ones that completely envelope the mattress, the pillow, the box spring, and you actually zip them and then duct tape the zipper so dust mites don't come through. Nasal steroids, antihistamines, and other nasal meds and nasal saline irrigation is used in the management and treatment of rhinitis. And in those other nasal meds, it could be that it's an antihistamine or a decongestant. Referrals, usually you want co-management with the specialist because oftentimes they come back to primary care for their allergy shot, their immunotherapy or allergy shots. And some patients do require immunotherapy. It does take about 6 months at least. They're usually on it for 2 or 3 years, so it's a commitment and it's expensive, but very worth it when it works. Older adults with new onset of symptoms of rhinitis, we've got to make sure that a nasal obstruction is ruled out. And then finally, in patient education and health promotion, it's really crucial for someone that suffers from allergic rhinitis, avoiding allergen exposure if all possible. They might even keep an allergy diary, and then the correct use of intranasal medications and other meds, because they can get complicated if they're using antihistamines, decongestants, intranasal steroid, leukotriene inhibitors. So really making sure that your patient understands. Thank you.